Excellent. 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 All right. Well, everyone has the minutes from the May meeting. So if you all have had a chance to review those, please take a moment now. If there are any discussion regarding the May minutes or any motions anyone would like to make?
I'll make a motion to approve the minutes.
I'll second the motion.
Thank you, Rocky and Brian. Motion to approve. All in favor, say aye or thumbs up. Yep. Thank you, Brian.
Aye.
All opposed? And any abstentions?
I will abstain as I wasn't here for last meeting.
Yep, sounds great. Thank you, Clayton. And we'll note that in the minutes, and the motion carries. Moving on to our next item here. If there were any, sorry, what was that? No, was there any housekeeping, Brian, for this meeting?
Just recognizing.
Yes, yeah. We want to thank Dr. Michelle Hoffman for her service to the Medicaid P&T committee, and she is stepping down from that role. And so we want to thank her for her service and expertise.
Yep.
And then we'll move on with Dr. Nguyen and the DUR board update.
Good morning, everyone. In June, the DUR board meeting meet to discuss the concurrent use of muscle relaxant with sedative hypnotic with opioid. And in July, the board meet to discuss the concomitant use of stimulant for ADHD and sedative hypnotic. And just last week, the board has met to discuss the antipsychotic use in adult. On of the minute, and the discussion topic is posted on the DUR website.
Excellent. Thank you. And then if we will move on to our fourth agenda item, the ACO update. I have Dr. Tran from Health Choice on first.
Hi, this is Dr. Tran. Am I allowed to share my screen? I'm not sure if I have that type of access.
You should be able to, but if you're not, did you send your slides over?
I did not, but it looks like I am able to. Let's give that a try. Did that work?
We see the presenter's view, not the presentation view.
Let's try the presentation mode. How's that?
I think you're sharing the wrong screen. Try unsharing and resharing what you have pulled up as the presentation, as opposed to the presentation mode. Presenters.
This might have to do. I don't know if that worked or not. My apologies. I don't want to take up any more time than we have to in order for your other agenda items. So I'll just go ahead and start. My name is Sam. I am with Health Choice Utah, presenting the preferred drug list methodologies today. So our PDL is developed and revised with direct input from our medical management committee, as well as the P&T committee and health choice protecting providers that could include nurses, doctors, pharmacists as well. We also utilize the Health and Human Services PDL Plus file that is given to us to review for PDL coverage. When looking at our formulary and making considerations, we look at new drugs, new formulations, new indications that are specific to the pharmacy benefit, and we review those drugs regularly. I would say about weekly, at least. Our formulary can be found on our website at healthchoiceutah.com. It's searchable, so you just type in a drug and it'll give you where that drug is placed. And the drug can be listed as preferred tier 1 or non-formulary tier 2, carved out and not covered. Forms and documents can also be found on our website, such as prior authorization request forms, as well as step therapy documents. And then also to note that we do communicate major changes to our formulary to our providers via the provider newsletter, as well as communicated via fax. Any significant impacts to our members are also communicated to our members as well. For our prior authorization, we do develop criteria to review for prior authorization. These criteria are written by pharmacists as well as physicians. We utilize clinical literature, practice guidelines, input from medical specialists, the PBM, drug manufacturers, as well as pharmacoeconomic data. All of our criteria are reviewed and approved by the P&T committee. Certain drugs, for example, high risk, high dollar, as well as non-formulary medications require prior authorization. And again, those forms can be found on our website at healthchoiceutah.com. These prior authorization forms can be submitted via our online portal or via fax. For the non-formulary category, there are formulary exception request forms that can be submitted via fax. We utilize PAs to be able to direct drug therapies to the most clinically and cost-effective drug products available on the PBL. For our Pharmacy and Therapeutics Committee, again, the prior authorization criteria is sent to the committee for review and approval. But they also serve other purposes, such as providing multidisciplinary input. The committee is made up of multiple providers, including MDs, pharmacists, and other providers as well. The P&T committee promote clinically appropriate drug use and positive member healthcare outcomes. And they also make the formulary determinations for inclusion. The committee meets at least quarterly. The recommendations are presented to the committee for formulary consideration. We look at medication efficacy, safety, cost effectiveness, and we discuss it during that meeting for consideration. Formulary decisions for newly approved drugs are decisioned within 180 days of market release, but we do put in the effort to get that decision for new drugs within 90 days. And that is the end of my slides. I will be happy to take questions or comments right now if you all have any. All right, I am hearing none, so I'll stop sharing and then you can move along in your agenda. Thank you so much for your time.
Thank you. Much appreciated. Next up from Healthy You, we have Dr. Britton.
Good morning, everyone. I believe I sent my slides to you, Trevor.
I'm not sure whether Trevor's on the call or not, but I do have those.
Oh,
Yeah,
okay.
Brian should have them.
Yep. Let's see. Let me get those pulled up.
If not, I have them also.
Yeah, I've got them pulling up. It's just taking a moment to load.
Very good.
Okay.
Okay. Thank you so much. All right. I'm here today, of course, to present the formulary methodology for Healthy You. Next slide. First of all, we do make the backbone, the preferred drug list, or PDL plus file from the state, which tells us what drugs are covered, not covered, carved out, or whether they have any kind of edits. We have the same structure. For years, it's preferred is tier 1, non-formulary is tier 2, carved out, and then not covered. Those drugs that are not covered are the ones that are designated by fee-for-service as not covered. We take seriously our fiduciary responsibility taxpayers to provide the best options to our members at the lowest net cost. So this includes assigning edits to ensure appropriate drug use. Next slide. We review new drugs, dosage forms, and indications on a weekly basis. We make recommendations for formulary inclusion based on the highest value, lowest net cost. And also, again, those edits are recommended. We regularly consult that PDL plus file before making coverage recommendations. And the ACOs would benefit from knowing the lowest net cost from the perspective of the state, but we don't currently have that. Next slide, please. Formulary inclusion for Medicaid coverage is determined by our Health Plan Pharmacy and Therapeutics Committee. This committee is comprised of primary care, specialty physicians, pharmacists, and nurses. We meet at least quarterly, and generally it's about 5 times a year. We are responsible on that committee to develop, manage, update, and administer the formulary. Next slide. Those formulary determinations are based on the most current clinical trials, treatment guidelines, pharmacoeconomic studies, FDA-approved prescribing information, safety data, utilization data, and other outcomes data. Clinical trials and clinical guidelines are considered when there are evidence-based, peer-reviewed, and relevant to clinical practice. Pharmacoeconomic data, pardon me, also includes total cost of care. So it includes drug cost, administration fees, and other healthcare expenditures related to the treatment in question. So that would include if a member has to go into clinic and get treatment and those associated fees. The committee considers the therapeutic advantages in terms of efficacy and safety in determining addition to formulary. Next slide. This P&T committee is responsible to review all FDA-approved new drug products within 90 days of release. If making a reasonable effort to do so, the committee's decision is ultimately has to be decided within 180 days of release to the market. Additionally, each therapeutic class is updated as needed or reviewed at least annually. Next slide. The formulary is dynamic and continuously revised. As mentioned, we meet at least weekly. It's posted real time on the Healthy You website at the website listed on the slide, and it is updated when changes are made. Any negative changes to the formulary are communicated to affected members as per the designated contractual timeframe, and significant changes to the Healthy You formulary are communicated to providers through a provider newsletter. Next slide. We have a drug utilization review process, and that is administered by our drug utilization board. And those things are reviewed and approved by the P&T committee. This includes edits for prior authorization, step therapy, and quantity limits. The Drug Utilization Board monitors all required Support Act DUR activities. Next slide. We use medication use policies or PA criteria to review medications, and those are reviewed and approved by the P&T committee. The criteria is based upon medical necessity, evidence-based medicine, and pharmacoeconomics. The requirements are posted online. As an integrated healthcare system, we also regularly consult with subject matter experts from the university before, during, and after the P&T process to ensure that our criteria and coverage determinations do not conflict with current prescribing practices. Next slide. The PA process is in place for certain high-risk, high-dollar medications, as well as non-formulary or non-preferred drugs. There appeared to have been some confusion between those two. In the past, we had listed drugs as non-preferred versus non-formulary, but that created confusion in and of itself because it wasn't the intent of Healthy You to have non-preferred drugs be considered as equally available as preferred products. So we have, over the last few years, made sure that our providers and members know that non-preferred means non-formulary. So if there was a question about that, please let me know. Prior authorizations may be submitted by faxing the form located on our website or submitting through our online portal. Exceptions to the formulary may be also submitted by faxing the formulary exceptions form. The formulary exceptions policy is also located online. Next slide. There is a formal appeals process in place for members or providers who disagree with our coverage determinations. The Healthy You formulary is in compliance with ACA Section 1557 regarding prohibition of discrimination based on race, color, national origin, sex, age, or disability, as well as other components of the ACA regarding essential health benefits. Next slide. And that's all my slides. Thank you very much. I'll take your questions.
In your presentation, you indicated that it would be helpful if DHHS was able to share information pertaining to those agents with the lowest net cost. And I just wanted to address that. Unfortunately, we're not able to share that information due to confidentiality of federal rebates that we receive on drugs. And so we're bound to not share that information. As general guidance, the best indicator of which drugs are higher cost versus lower cost is the preferred drug list that we publish for fee-for-service members.
Thank you for that clarification. Not hearing any other questions, we will move towards Molina and Dr. Goodrich.
Hey everyone, good morning. And then Brian, I also sent in my slides to you, but I can present either way.
I've got those pulling up now, and I'm happy to present.
Thank you.
Unfortunately, PowerPoint's going a little slow for me this morning.
It's okay. Morning, everyone. My name is Heidi Goodrich. I'm the Health Plan Pharmacy Services Manager from Molina, Utah. And I will be presenting our PDL strategy. Next slide, please. Molina Healthcare is a Fortune 500 company. We provide managed healthcare services under Medicaid and Medicare programs, as well as through the state insurance marketplace programs. We have 5.5 million covered lives across 21 states. We have a National Pharmacy and Therapeutics Committee that acts as the clinical governing body for all drug-related activities across our enterprise. This committee is made up of external doctors and pharmacists within our Molina networks, and that membership is a mixture of clinicians who have a variety of specialties. Our P&T committee meets at least once quarterly, and they report into our National Quality Improvement Committee. We also have various subcommittees that roll up to our national P&T, including our monthly policy voting committee that meets at least once monthly and has state representation for all our states. I am the representative for Utah, and we make recommendations based off of state specific requirements and dynamics. We also have a DUR board that reviews utilization activities across the enterprise. And then we also have a PA core committee that regularly updates and reviews drug criteria at least annually. Next slide, please. And then on this slide, I designated as far as which formularies Molina is able to apply our own strategy for, which includes New Mexico, Nevada, South Carolina, and Utah. We also have our own marketplace formulary, and then we also have a handful of states that act as advisories to state formularies. For various utilization management strategies, we apply PA, step therapy, quantity limits, and we also drive generic utilization. We also have quality monitoring and provide DUR program and board oversight. As part of the National P&T Committee, they also evaluate our internal policies and procedures, as well as external communications to educate providers. Next slide, please. For our preferred drug list, we cover many different types of drugs that treat a wide variety of diseases and medical conditions. Our formulary has two tiers. Tier 1, it contains our preferred generic drugs. Tier 2 contains the preferred brand drugs, including our specialty drugs. As previously mentioned, we apply various utilization controls that are found on the preferred drug list for members and providers to reference, including step therapy, age and quantity limits, prior authorization, generic drugs that are therapeutically equivalent to the brand name drug, as well as opioid edits to follow the state MME daily limits. Next slide, please. We evaluate a variety of things as far as determining the preferred drugs that we cover, including that it is a covered drug and benefit per Utah Medicaid and CMS rules, FDA approved indications and dosage limits, safety and reported adverse events, quality, that the drug treatment is supported by national guidelines for practice standards that are accepted by the medical community. We make sure that these drugs are effective. They must be proven and comparable efficacy to non-formulary drugs, drug utilization trends of clinically similar medications, the brand and generic pipeline, the economic value as far as the net cost and market share, and the Medicaid drug rebate program, as well as impact on our members. Next slide. Preferred drugs for coverage are found on the drug formulary. We cover many drugs that are not listed on the formulary. In order for a provider to request a non-preferred drug, a medication exception prior authorization request can be submitted with all necessary clinical documentation. And within that medication exception form, that form is hyperlinked within there. All drug prior authorization forms can be found on the Molina Utah Medicaid CHIP provider page under our forms section. And we have a section that contains all of our drug prior authorization forms. And these forms are also hyperlinked within our drug list and formulary section. We also have a pharmacy FAQ section that addresses many commonly asked questions as far as which medications are or are not covered, how to submit drug prior authorization requests, and it has hyperlinks to other resources that members and providers find to be useful. And then I also included links to our searchable formulary and preferred drug list here. And that concludes my presentation for today. Any questions? Okay, thank you.
Thank you very much. Next up, we have Dr. Eshelman from Select Health.
And Dr. Eshelman, let me know if you need me to present the slides. I've got those loaded and ready. Or if you would like to present, that's fine too. I saw her on screen, but she appeared frozen. Let's give her just a moment to try that again. You see that someone just called in.
Hi, all. I'm so sorry. This is Sam Eshelman. I had a power surge right when it pushed me, so that was unlucky timing.
Oh no. Well, I have the slides pulled up and I can present those if.
That would be wonderful. Since I'm on the phone, I can't see which slides you're on, so I'm just going to hope that you're on the first slide.
Yep, I've got the introduction slide pulled up and I'll advance as you direct.
Thank you so much. Again, I apologize. That's rough timing. Okay. So a little bit about Select Health. I'm sorry, I'm Sam Eshelman. I am the manager for government formularies here at Select Health. A little bit about Select Health is we're a not-for-profit organization and we're part of an integrated system with Intermountain Health. We work together with Intermountain for shared clinical integration, clinical programs, and patient initiatives. The programs and initiatives that we work together on continue to provide patients high-quality healthcare, as well as demonstrate our commitment to the community to help people live the healthiest lives possible. Next slide, please. Collaboration and working with Intermountain, we have developed and implemented multiple clinical work groups and care process models. Examples of these CPMs include asthma, diabetes, hypertension, ACS, stroke, oncology, pain, etc. As well, these CPMs are reviewed and updated regularly. Next slide, please. We do have our own pharmacy and therapeutics committee, which meets monthly. The committee is comprised of local practicing physicians and specialists, as well as pharmacists from a variety of clinical specialties. Based on their knowledge and experience, the physicians and pharmacists provide insights to local healthcare trends and help them understand how their decisions impact their patients. Each therapeutic category is reviewed at least annually. Next slide, please. For the formulary, Select Health covers all medications listed on the PDL file from the state. All new drugs approved by the FDA have a determination made by our committee within 90 days of release onto the market. So just to clarify, we do cover the drug immediately upon its availability on the PDL, but the way it is covered may change within the 90 days after our committee reviews. The formulary consists of 4 tiers. We have generics, then preferred brands, then non-preferred brands, and specialty products. Our specialty products are typically anything that has a cost over $1,000 per script. For formulary, we were asked to define what our non-preferred and non-formulary drugs are. For non-preferred, these are drugs that either have a step behind a preferred agent or has a prior authorization that includes steps through preferred agents in addition to clinical criteria. For non-formulary, these are drugs that are not on the PDL or specifically excluded from Medicaid coverage, such as weight loss or erectile dysfunction drugs. Next slide, please. For utilization management, based on the decisions of the Select Health P&T Committee, our may include PA, step, or quantity limit restrictions for our covered medications. These may be added, removed, or modified as determined by our P&T Committee. We did include a link to where our prior authorizations and set therapy criteria can be found. There's a hyperlink as well as a URL. Next slide, please. There are a variety of factors that we consider when looking at drug and medication class reviews. This can include clinical efficacy or effectiveness. This includes clinical trials, clinical guidelines, things of that nature. Safety, this could include the MME edit for opioids. Special considerations such as drugstore or dosage forms like our solution and dissolving tablets for our pediatric population who may not be able to swallow tablets and capsules. Special handling, this includes the refrigeration, such as with our biologics or insulin. Special populations here, we're making sure we're taking care of our vulnerable populations with our pediatrics, our elderly, renal, and liver impairment patients. We look at current drug utilization trends, as well as our DURs and cost consideration. Next slide, please. And with that, I will open it up to any questions. Thank you all. Apologies for the technical difficulties.
Thank you for your presentation and thank you for working through those difficulties. And Dr. Sloan had to step away, so I'll be taking over conducting the meeting from here. Next up, we have a review of hereditary angioedema treatments, and Dr. Valerie Gonzalez is going to be giving that presentation.
Okay. Can you see those slides all right? Yeah, I think those are up. Okay. So hereditary angioedema, abbreviated HAE, is a rare disorder of severe swelling episodes referred to as HAE attacks. Swelling locations typically affect the skin, GI tract, upper airway, the face, and/or throat. HAE-induced laryngeal swelling is life-threatening and necessitates immediate rescue therapy. While there is heterogeneity across the affected population regarding attack frequency, severity, and attack locations, attacks are often spontaneous and unpredictable. Some episodes may be foreseeable upon common triggers such as physical trauma, especially dental procedures, emotional stress, fatigue, infections, or certain medications such as estrogens. Most HAE cases are caused by genetic mutations in the protein C1 esterase inhibitor, abbreviated C1-INH, that regulates the production of bradykinin, which is a potent vasodilator and enhancer of vascular permeability. These cases are classified as HAE C1-INH in which mutations cause inadequate C1-INH plasma activity. Rarer cases generally have normal C1-INH levels and function. These cases are classified as HAE normal or NL C1-INH and encompass heterogeneous subtypes with different causative genetic mutations. The pathology of this group is less well understood, but excess bradykinin is also implicated in some subgroups. HAE affects approximately 1 in 50,000 people. In 2023, the US prevalence of each main type was estimated as follows: 45 to 5,200 patients with HAE C1-INH and 12 to 1,300 patients with HAE normal C1-INH. The age of disease onset is variable, but is often during childhood. This disease has significant negative impacts on quality of life. Many patients live in fear of when a laryngeal attack might occur. Attacks can be debilitating and painful, and the anticipation of attacks can confer considerable psychological anxiety and distress. It is estimated that more than half of the affected population with HAE will experience at least one life-threatening attack affecting the airway during their lifetime. Without reliable treatment, patients may avoid common daily and physical activities. Some HAE treatments can also be burdensome, impacting quality of life. HAE-related swelling is unresponsive to common agents used for inflammation or airway constrictive reactions, such as antihistamines, glucocorticoids, or epinephrine. So HAE-specific treatments are used for the management of this disease. Treatment strategies include providing an on-demand rescue agent for treatment of an active attack. Rescue therapies are recommended for use at the onset of any HAE attack. Depending on the patient's needs, management of HAE may also entail providing prophylaxis therapy for either short-term prophylaxis of an anticipated attack prior to known triggers, or for long-term prophylaxis to decrease the frequency and severity of unpredictable attacks. Currently approved medications for HAE therapeutically function by either replacing C1-INH plasma levels, as with the C1-INH concentrate products, stimulating C1-INH production, as with danazol, inhibiting production of bradykinin activation through the kallikrein enzyme, or treating or targeting bradykinin receptors to halt or prevent HAE symptoms. HAE medications are approved for either acute treatment of attacks or for prophylaxis therapy to prevent attacks. Additional key differences include their approved age for use and characteristics that are relevant to the ease of use, such as the route of administration, the need for reconstitution for injectables, self-administrability, or dosing frequency for prophylaxis agents. On-demand rescue medications approved in the US include 2 C1-INH concentrates. Reinert is a plasma-derived C1-INH product, and Ruconest is a recombinant C1-INH product. Additionally, there is the kallikrein inhibitor ecallantide and the bradykinin receptor antagonist icatibant for on-demand use. The 2 C1-INH concentrates are intravenously administered, require reconstitution, but can be self-administered by trained patients and or their caregivers. They are approved for adults with HAE and either for pediatric patients in general, as with Reinert, or for adolescents, as with Ruconest. Ecallantide is a subcutaneous product approved for patients 12 years and older. Its usability outside of the clinic, however, is limited due to the requirement for administration by a healthcare professional who can respond to a potential anaphylactic reaction. Icatibant is a subcutaneous injection approved in the US for adults only. This agent may be the most convenient on-demand product for self-administration because it does not require reconstitution or IV administration. Approved prophylaxis agents include the attenuated androgen danazol, the plasma-derived C1-INH concentrates Cinryze and Haegarda, and the kallikrein inhibitors lanadelumab and berotralstat. Danazol is an older oral agent generally indicated for prevention of HAE attacks with daily dosing. The two C1-INH concentrates are indicated for routine prophylaxis for the youngest age of at least 6 years old and are administered twice a week, but by different routes. Cinryze is an intravenous product and Haegarda is a subcutaneous product. These products require reconstitution and can be self-administered with training. Outside of the US, Cinryze also has approval for pre-procedural prophylaxis, which is referred to as short-term prophylaxis, and is also approved for on-demand treatment of attacks because it is intravenously administered, so is rapidly bioavailable. The prophylactic kallikrein inhibitors, lanadelumab and berotralstat, are both indicated for patients 12 years or older. Lanadelumab is subcutaneously administered, and berotralstat is the first oral medication available for long-term prophylaxis. Lanadelumab is administered least frequently of the prophylactic agents with every 2 or 4 week dosing intervals. It does not require reconstitution and is self-administered. Oral berotralstat is administered daily. We will now look at clinical guideline recommendations. These 3 guidelines are the most recent guidelines that we are aware of. Clinical treatment guidelines recommends providing rescue therapy for all patients with HAE to be used at the onset of any HAE attack to reduce the duration and severity of the attack. The FDA-approved agents for on-demand therapy are all considered first-line options. Guidelines from outside of the US include Cinryze as an on-demand option as well. Providing readily accessible on-demand medication to patients with HAE is a strong recommendation by guidelines since attacks can be unpredictable and life-threatening. It is inferred that a self-administrable on-demand product is preferable for ambulatory patients rather than relying on modalities limited to urgent care or inpatient use, as with ecallantide or off-label use of fresh frozen plasma. Guidelines emphasize the importance of early treatment of attacks, since early rather than later treatment is associated with better outcomes. Additionally, the US guideline describes that because HAE is rare, HAE-specific medications may not be available in hospitals or emergency departments, so should be prescribed to patients to have readily accessible. Treatment with fresh frozen plasma in an emergency care setting is considered a last-line approach. Short-term prophylaxis, abbreviated STP, is recommended before any known trigger or stressful event that could trigger an attack, such as medical, surgical, or dental procedures for all patients with HAE, including HAE normal C1-INH. Intravenous plasma-derived C1-INH products are generally the treatment of choice for STP. Danazol is an alternative along with recombinant C1-INH Ruconest, for which guidelines note positive but limited evidence in the setting of STP. Long-term prophylaxis, or LTP, is considered for patients based on attack frequency and severity, disease burden, and quality of life, and practical factors such as the patient's ability to administer LTP, their access to emergency care, and ability to administer on-demand medication. For HAE type 1 and 2, the FDA-approved prophylactic therapies with the exception of danazol, are recommended first-line options for LTP. Because danazol has a high adverse event burden, along with many drug interactions and contraindications, it is reserved as a second-line option in the event first-line agents cannot be used. For HAE normal C1-INH, other off-label agents are recommended first-line. Guidelines mention considering C1-INH concentrates or lanadelumab on a trial basis if other options fail. With respect to on-demand treatment for children, the U.S. guidelines suggest that plasma-derived C1-INH is preferred, but this is not specified at the level of a formal indication. Other options with positive evidence, which may or may not have FDA approval, are also described by guideline authors. Plasma-derived C1-INH is also recognized as the treatment of choice for prophylaxis in children for both STP and LTP. The U.S. guideline also recognize lanadelumab as an option for LTP in this population. Long-term use of androgens is generally reserved as a last-line option and only after reaching Tanner developmental stage 5 due to the risk of adverse effects on development. During pregnancy, generally, C1-INH concentrates are the recommended treatment for on-demand and prophylactic treatment. Plasma-derived products are most often used. Several agents have contraindications and or labeled warnings regarding hypersensitivity. This includes all C1-INH concentrates, ecallantide, and danazol. Labeling for plasma-derived C1-INH products highlight that epinephrine should be dispensed to patients on these therapies to be able to respond to a severe allergic reaction. Ecallantide requires administration in a clinic due to the risk of anaphylaxis. All C1-INH products and danazol have a warning for rare but serious thromboembolic events. This is a black box warning for danazol. Danazol is contraindicated in many other subpopulations, including patients with cardiac, hepatic, or renal dysfunction and during pregnancy. Notable common side effects include injection site reactions with several of the injectable products and GI-related adverse events with oral berotralstat. Common adverse events associated with ongoing use of androgens, such as danazol, include weight gain, virilization, myalgias, hypertension, mood changes, and abnormalities in liver enzymes and LDL cholesterol. Currently, there are no available head-to-head trials that compare the reviewed on-demand or prophylactic HAE medications. However, differences in their ease of use that could influence time to treatment of an active HAE attack for on-demand agents, or that could influence the burden of treatment for LTP could be considered during the decision-making of preferential status for purposes of the Utah Medicaid PDL. At least one agent that could be self-administered for on-demand treatment of HAE attacks could be considered for preference for both children and adults as the same agent or different agents for the respective age groups. Of the products FDA approved for on-demand treatment, ecallantide should not be self-administered, where others are self-administrable. A self-administered product would allow the patient to have the medication on hand in the event of a potentially life-threatening attack. Moreover, some emergency departments may not carry HAE-specific medications, so patients should be prescribed these therapies. Moreover, it is generally recommended to treat at the onset of an attack rather than delaying treatment. Additionally, at least one guideline recommended first-line prophylaxis agent could be considered as preferred on the Utah PDL. All agents FDA approved for HAE prophylaxis meet this specification except for danazol. If an IV agent is chosen for preference, other non-IV options can be made available via prior authorization, considering the potential burdens that can arise with IV products, such as loss of IV access, among other issues. Notably, patients with HAE also require short-term prophylaxis when undergoing medical procedures, especially those that affect the larynx or oral cavity, or in anticipation of a known attack trigger. IV plasma-derived CO1 INH concentrates are used and guideline recommended for STP, so the PDL may also include an IV plasma-derived CO1 INH product as preferred, if not already selected to satisfy the other therapy goals. All right, and that's all I have for you. Please let me know if you have any questions.
Thanks, Val. That was an excellent presentation. We do have one person on the agenda for public comment. So we've got Giuseppe Miranda presenting. So Dr. Miranda, we've got 3 minutes for your, and the floor is yours.
Perfect. Yeah, thank you, Brian. Hi, good morning, everyone. I appreciate the opportunity to present today. I'm Giuseppe Miranda, and I'm an MSL at BioCryst, which is the manufacturer of berotralstat, or Orladeyo. And I'm here to give a clinical update on berotralstat, safety and efficacy in hereditary angioedema, or HAE. So Orladeyo was approved in December 2020, becoming the first oral targeted agent for prophylaxis to prevent attacks of HAE in adults and pediatric patients that are 12 years of age and older. And Orladeyo is the only first-line treatment and does not require the only oral first-line treatment and does not require additional supplies for storage or administration. Now, since our approval, just to keep you updated on some of our new data, newly published data from part 3 of our pivotal APEX-2 trial shows that berotralstat demonstrated continued safety and effectiveness over long term, with sustained improvements in HAE attack rates over 24 months of treatment, with a 90.8 average reduction in attack rate from baseline for those on the 150 milligram of berotralstat. Also, real-world evidence collected from Orladeyo patients in the US continue to support evidence from the APEX-2 trial. And in particular, Orladeyo real-world evidence also has demonstrated effectiveness in patients with HAE with normal C1 inhibitor. Now, Orladeyo is generally well tolerated, where most common adverse events that are seen are GI related. So that would be your abdominal pain, nausea, vomiting, as is reported with many oral medications. But with Orladeyo, these adverse events were mild to moderate, short lasting, and self-limited, and are typically reported less by patients over time. So in addition to significant decreases in attack rates and improvements in patient satisfaction and quality of life, patients treated with Orladeyo in clinical trials used fewer doses of rescue medication and treated fewer attacks after 4 weeks in Orladeyo. And at 24 months, rescue medication was reduced by an average of 2.4 doses per month versus baseline in patients receiving Orladeyo 150 milligrams. And from newly published retrospective real-world data utilizing 2015 to 2022 administrative claims data, we showed a significant reduction in the overall rates of all-cause and angioedema-related hospitalizations, as well as outpatient and ER visits after initiation of berotralstat. Now, these data overall reinforce that Orladeyo is generally well tolerated, is effective in reducing HAE attack rates, and the use of rescue medication and other healthcare resources in patients with HAE. And today, Orladeyo is the only oral option for targeted HAE prophylaxis and is recommended in the World Allergy Organization 2021 guidelines as first-line long-term prophylaxis in HAE. So with that, thank you for your time. We appreciate you giving all patients access to HAE therapies. And yeah, with that, I'm happy to take any questions.
Thank you very much.
Yeah.
Does anyone have any questions for Dr. Miranda? If not, we'll open the floor to discussion about the hereditary angioedema agents in general. So this is a topic that I'm still learning, and there's a lot to consider. But as we consider our options for preferred agents, to me it seems that it would be appropriate to have at least one preferred agent for prophylaxis as well as for acute treatment, and at least one agent that can be self-administered in both cases. I wonder if anyone else on the committee has any thoughts on that, and also whether we should also be considering the short-term prophylaxis for the surgical and stressful events, if that should be considered separately or simply prophylaxis versus acute treatment. Yes, Dr. Siegfried.
Yes, I did want to make just a few comments or proposals. First, that the 17 alpha alkylated androgens, specifically danazol, but also stanozolol, which is much older, be considered non-preferred given their contraindications in pregnancy, children, and multiple drug-drug interactions with other medications. Even though they are fairly inexpensive relative to the other medications in this class, it seems that the risks outweigh the benefits. And from the prior auth form from last week, I just wanted to mention that the Drug Utilization Review Board suggested that in terms of on-demand or rescue treatment, that when applicable, 2 doses be allowed per individual to have on-demand therapy. Oops.
I think those are reasonable recommendations. So just to summarize, you're recommending that danazol be considered less safe and efficacious for consideration on the preferred drug list and should be non-preferred, and that at least 2 doses be available for acute treatment.
When applicable, depending on the agent.
Right. Okay. Would you like to put that into a motion?
I move that that danazol be considered a non-preferred agent due to the risk outweighing the benefit. That's number 1. Number 2, that in terms of on-demand or rescue treatment, at least 2 doses be available to each individual when applicable. And third, I will do my due diligence and also propose that we have a grandfathering clause for those who are currently stable on medications that will not be considered preferred either for prophylaxis or on-demand treatment.
All right. Thank you for that. Do we have a second?
I will second that.
Thank you. All in favor?
Aye.
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 Any opposed? All right, I think that's unanimous. The motion carries. And then I think that covers some of the complications around the class. I would like to also propose that we have at least one preferred treatment for one. Excuse me. We have at least one preferred acute treatment and at least one preferred prophylaxis treatment. In both cases, something that can be self-administered. And so I'll make that motion, and could we have a second?
I'll second that.
Thank you. All in favor?
Aye.
Aye.
Aye. Any opposed? All right, motion carries. Our next meeting will be in November. We'll be discussing treatments for Duchenne muscular dystrophy. And that concludes our meeting. We have a motion to adjourn.
I move to adjourn.
And I'll second that. Thanks, everybody. We'll see you in November.
All right. Thank you.
Thank you.